Hello, and welcome to the CME on Cushing's disease, with highlights of research presented at the Endocrine Society meeting in Chicago in June of 2023. I'm Lisa Nachtigall. I am the clinical director of the Neuroendocrine and Pituitary Tumor Clinical Center at Mass General Hospital and an associate professor of medicine at Harvard Medical School in Boston. I welcome you to the CME on Cushing's disease, research highlights from Endocrine 2023. Here are my disclosures. And here I'd like to just remind you what Cushing's is. So this is a rare endocrine disorder characterized by excessive cortisol. Cushing's syndrome refers to this whole phenotype of signs and symptoms, including weight gain, hypertension, diabetes, hirsutism, acne, hair loss, bruising, muscle weakness, atrophy of the extremities, poor wound healing, infections, insomnia, mood changes, amenorrhea, and irregular menses in women can occur. But when this syndrome is specifically related to a pituitary tumor secreting excessive ACTH, it is called Cushing's disease, and that is the topic of today, particularly related to the new developments that were presented in the Endocrine Society meeting last June. Just to remind you, for those of you who don't see this and think about it every day, there are very specific clinical features of Cushing's syndrome. Facial rounding, supraclavicular fullness, and posterior cervical fat pad is illustrated by the severe case seen here. And also here is a dramatic display of the central obesity and striae associated with this disease. Of all of the endocrine axes, the hypothalamic pituitary adrenal one is so critical to health and disease. And in fact, it is not only in Cushing's disease and Cushing's syndrome from tumors that we see issues here, but stress itself from any cause will heighten this axis and be associated with hypercortisolemia. When it comes to Cushing's syndrome, an endogenous excess of cortisol can be due to three possible causes. The topic of today is Cushing's disease, and you can see here the pituitary tumor, which is an ACTH-dependent process. Also ACTH-dependent next to that is an ectopic source of ACTH, for example, in a lung cancer or other neoplastic tumor outside of the pituitary. In both the cases of ectopic ACTH and in pituitary tumors causing excessive ACTH, you will see elevated levels of cortisol in association with a high or inappropriately non-suppressed ACTH, as opposed to the adrenal causes of Cushing's, where the ACTH will be low. Don't forget that in the setting of a low ACTH, think about possible exogenous sources of Cushing's. Patients won't always tell you that they've taken a cream, a gel, or had a steroid shot 3 months ago, but those can also cause Cushing's and would be associated with high cortisol levels and a low ACTH. I refer you to the wonderful summary recently published in the Lancet in 2021, where my colleague Maria Flescherow was the first author, and it reports the results of recent guidelines from 50 experts that was organized through the Pituitary Society. And there's a beautiful algorithm shown here and in that publication. But let's focus on what happens after you've made the diagnosis of Cushing's disease and have had pituitary surgery and yet experience persistent Cushing's. that is when medical therapy is required, and that is the time where there is some relevant information coming forth from this latest Endocrine Society meeting. Thinking about the medical therapies currently available, and by the way, this field has really progressed in the last decade. There are medications that will bind directly to tumor receptors. As you know, there's pasireotide, which is a second-generation somatostatin receptor ligand, where you can treat Cushing's with this medication, and it will bind to the somatostatin receptors on the tumor. Cabergoline, which many of you know for its use in prolactinomas, will also be of use in some ACTH-secreting tumors, and those are dopamine agonists, and they bind to the dopamine receptor. Glucocorticoid receptor blockers are now available, that's mifepristone, and then there are several adrenal steroidogenesis inhibitors. And one of these new ones is osilodrostat. Another new one is levoketoconazole. And osilodrostat had some studies that were reported at the Endocrine Society annual meeting held in June in Chicago. And these abstracts are actually published online in the Journal of the Endocrine Society if you want to read through them directly. But here I will give you the highlights. And the clinical trials that were presented at the meeting were quite interesting because there was a summary of 3 trials on osilodrostat that really allowed us a flavor of how this drug works in a larger subset of patients with Cushing's disease over a long period of time. So these authors verged the results from 3 different trials in an abstract. And those trials included the phase 2 study, which had an extension period, a phase 3 study, which was a 48-week study and had a double-blind randomized withdrawal period within it. And then there was a 12-week randomized double-blind placebo-controlled period, followed by a 36-week open-labeled. And what they did here is they removed the placebo data, which had varied so much in these trials, but they pooled the data from patients receiving this drug. And actually, in all 3 of these trials, the starting dose was 2 milligrams twice daily. But there was a variable ramp up anywhere from looking at levels and adjustments at every 2 weeks to every 3 weeks to every 4 weeks. And that varied in the different studies, and all of them are pooled together here. But what you can see is that within these 3 trials, where there were 220 patients collectively studied, the median duration of therapy was 100 weeks, so they had quite a long time. The daily dose was 6.8 milligrams, so we're looking at about 3 to 4 milligrams BID for their median dosing. The dose needed for urine-free cortisols to become controlled varied greatly. The time to urine-free cortisol normalization median was 35 days, so about a month, plus or minus. And the time to the first adverse event of special interest was 12 weeks. And that includes patients that became adrenal insufficient, had symptoms from that, or patients that had symptoms from the accumulation of adrenal hormone precursors. In order to really understand those side effects, it is worth a moment to go back and look at the pathways of steroidogenesis in the adrenal gland. And I think by doing this, I hope I don't remind you too much of your biochemistry days if that wasn't a fun thing for you, but it really will help you understand this drug when you look at this figure, which shows you that the inhibition of the 11-beta hydroxylase step in the steroid synthesis results in decreased cortisol. So just to take one point here, this drug will work in any type of Cushing's disease syndrome, whether it's an adrenal tumor or a pituitary tumor. Therefore, it doesn't have to only be used in Cushing's disease, but in these studies, it was. What you are going to see is a decrease in your cortisol and a decrease in your aldosterone. But what you also may see by blocking this particular enzyme is an increase in the androgen, the precursors to before the step in inhibition, and that will include the 11-dehydroxycortisol, testosterone, and 11-deoxycorticosterone. So when you think about these side effects, you can think about the drug working too well and causing adrenal insufficiency, or potentially increasing androgens and having side effects from those in women, which most patients with Cushing's disease are. Conclusion from this pool data showed that osilodostat led to sustained mean urine-free cortisol control in all 3 studies. The time to control was actually shorter in patients who started with lower mean urine-free cortisol values. The median dose, as mentioned, was 6.8 milligrams as a total daily dose, but it varied widely. And dose titration regimens differed in each study slightly, but overall, the adverse events were less frequent during the long-term treatment than while the dose was being titrated. Most managed this without having to stop treatment. It also makes the point that personalized therapy during these titrations are critical. There's a lot of variability in the doses that were needed, and lifelong monitoring is really necessary to optimize outcomes in patients with Cushing's disease. Another very interesting poster was presented by my colleague with the first author, Beverly Biller. And they asked a really interesting question in the second abstract of pooled data from these same 3 studies. And the question was trying to compare and evaluate outcomes on osilodostat using different metrics of control. So the question was, if you control just urine-free cortisol versus controlling both late-night salivary cortisol and urine-free cortisol versus not achieving complete control, how do the outcomes differ? And looking at 72 weeks, interestingly, regardless of how control or not, you see that physical manifestations improved in all. Also, interestingly, the greatest improvements in cardiovascular and metabolic related parameters and quality of life were observed in patients who had controlled urine-free cortisols or controlled late-night salivary cortisols and urine-free cortisols. And you can see in this table the variation of improvement seen based on how the group was controlled, how well they were controlled, with a group here showing controlled urine-free cortisol and late-night salivary cortisol with the highest 72-week improvements in fasting blood sugars, hemoglobin A1C, weight, and waist circumference. Also very closely, similarly improved in urine-free cortisol alone, and less improvement in these specific parameters of fasting glucose, hemoglobin A1C, weight, and waist circumference in those that did not achieve control. Moving on to the next phase of this research highlight section is looking at petrosal sinus sampling in Cushing's disease and asking the question, does desmopressin increase prolactin secretion? And the reason that this is relevant is, as you know, we use bilateral inferior petrosal sinus sampling when there is ACTH-dependent Cushing's, and we're not sure if it is due to a central process from a pituitary tumor or if it's from an ectopic tumor. And in that setting, we have always used CRH to enhance the accuracy of this test. But in more recent years, CRH is unavailable. And instead, we have been using desmopressin. And this study looked to see, is if desmopressin increased prolactin, since it had shown that CRH in this setting had increased central prolactin. And it turns out that in 30 petrosal sinus samplings performed with desmopressin, which ended up including 24 patients that were confirmed to have Cushing's disease, compared to 6 patients that had ACTH ectopic disease, that in that setting, 50% of the petrosal sinus sampling showed that there was an increase in central prolactin after desmopressin, and none of the ectopic cases had an increase in prolactin with desmopressin. So this is an interesting distinction, more of a distinction than that was shown previously with CRH, that may have some use for future diagnosis. It also was interesting to know that the ultimate pathology in terms of staining for prolactin did not correlate with this stimulatory effect of desmopressin. So more to come on this, just an interesting little sidebar on desmopressin and its possibility of increasing prolactin in Cushing's disease and not possibly in other sources of Cushing's. Comorbidities were looked at, and there were 2 that I will show you here, abstracts focused on thrombotic events. So this is a really important topic and an unmet need in the field, since we do know very well that there's an increased risk of thrombotic disease in patients with Cushing's. Exactly how much of the increase there is and who is most likely to get it, and more importantly, what strategies should be implemented to prevent thrombosis, is not yet determined. So more studies on this are critical, and this was a very large one. There was 2,173 patients with Cushing's syndrome. 95 of them were found to have thrombotic events, and this included 57 centers from 26 different European countries, and ended up showing a prevalence of 4.4% of thrombotic disease in patients with Cushing's. These patients were 14 to 75 years. Their median age was 47, 66% were female, 22% were smokers. In the 95 thrombotic events, 74% were pituitary, 13% adrenal, 10.5% were ectopic, and 3% were due to other causes. But most importantly, and I want to highlight this point, if you looked at the patients with VTE that had Cushing's due to ectopic disease, it was 10.5%, compared to only 5% in those that didn't have thromboembolic disease. So there were many more proportion of patients with VTE that had ectopic sources than in the population that was studied. In other words, that being ectopic is a risk factor for thromboembolic disease. In addition, 3/4 of these patients were either overweight or obese with a BMI greater than 25. The most frequent comorbidities were hypertension, diabetes, and osteoporosis, and the VTE group had more numerous surgeries. So the mean operation per patient was 1.4 for the thrombotic event group compared to 1.2 for those that did not have an event. Of course, that makes sense. If you have more surgeries, you have a higher risk overall of being exposed to something that is going to stimulate a perioperative event. VTE is a concern in patients with Cushing's disease for sure, and these studies confirmed that again, obesity and hypertension are common comorbidities in the group that have thrombotic events, and over half of these occur even at a time where the patient's cortisol is normal. So I think we need more information on how to strategize prevention, but it is interesting to have this very large database to help us understand some of the risk associated with perioperative thrombotic risk in patients with Cushing's. And one other study, much smaller study, was 51 patients in a single center study. They also wanted to determine the prevalence of thrombotic events in patients with Cushing's disease who underwent surgery, and this was done at the University Hospital of Wales. They had 51 patients, of whom 36 were women, and 9.8% had a thrombotic event. 2 were prior to surgery, 3 were within 21 days following surgery, and there was no correlation between the cortisol levels and the thrombotic events in this study. And they also conclude what so many other meta-analyses have concluded, that the timing, dose, and duration of prophylactic anticoagulation needs to be further studied. So I think we can all agree on that. And finally, I will leave you with a quality of life study by my colleagues at Sloan Kettering in New York, where they've done some nice education for patients with Cushing's disease, and they reported some surveys from patients compared to physicians at these courses over 2020 and 2022 during their symposiums on Cushing's there. And they found that the patients thought that they had no choice in treatment more than the physicians thought this, that the patients had a lot of hope for improvement, much less than the physicians thought they did. But interestingly, physicians thought that the patient was more anxious about their disease. 94% of physicians thought the patients were anxious, and only 65% of patients suggested that they were anxious about their disease. The patients reported feeling alone living with Cushing's, 60% of them, compared to 45% of the physicians who thought that the patients felt that they were alone. The most common personal goal for the patients with Cushing's disease was quality of life and mental health, whereas the physicians thought it would be medical therapies and tumor control. And similarly, the patient's most perceived unmet need was education and awareness, while the physicians thought it would be medical therapies and tumor control. So the perceptions of this rare disease did differ between patients and physicians, and that is a theme that we have seen in other rare diseases and also in other pituitary tumors. I will just summarize the clinical pearls that we have reviewed today that were presented at the Endocrine Society meeting in June of 2023 that pertain to Cushing's disease. And the first point was that long-term use of osilodrostat appears to be safe, effective, and well-tolerated. And when merging studies from clinical trials, we see that the greatest improvements in cardiovascular and metabolic-related parameters and quality of life were observed in patients where either their urine-free cortisol alone was controlled, or their urine-free cortisol and their late-night salivary cortisol was controlled. Venous thromboembolic disease was present in over 4% of a large European database, and most of these were overweight or obese. One other single-center study showed that 9.8% of their patients with Cushing's disease had a thromboembolic event. Patients' and physicians' perceptions of Cushing's disease and the treatment options available to them are quite different. I hope this provided a summary of the highlights in case you missed the research on Cushing's disease presented at the Endocrine Society in June of 2023. I also will remind you that you can go to the Journal of the Endocrine Society and read for yourself all of the abstracts that I highlighted for you here today. Thank you so much for joining us on this program on Cushing's disease. I hope it will be useful for you and for the patients you treat.